good afternoon everybody. I'm Maarten Beelen, one of the founders of Precise, responsible for system integration and software. So I'm an engineer, unlike the MD that they put on my badge. But I'm involved in a lot of application development because I agree with Tom that is very important to find clinical evidence, first hypothesis, and after that clinical proof when you want to bring a product to the market. So I'm half of the engineering team and we're with 6 people, so that gives you an idea. So Precise develops technology, robotic technology for eye surgery. Vision loss is a big problem. It affects more than 4% of the global population and of course has a large impact on quality of life. Most of the diseases are in the front part of the eye. Most surgeries are performed there, like replacing the lens in case of cataracts. But those procedures are quite easy. Surgeons can perform a great cataract procedure in like 15 minutes with a low complication rate. So Precise's initial focus is on vitreoretinal surgery on the backside of the eye that really requires highly skilled surgeons in terms of precision and steadiness. And the Precise system can provide extremely high precision and dexterity, so that's a good match. Vitreous disorders are the largest cause of vision loss in developed nations, and it's expected to double by 2030 due to aging and smoking, diabetes, the usual suspects. But only limited treatments are available because the precision of the human hand is limited, of course. So we think with precision, with improving this precision, we can enable new treatments. But also existing procedures have limited access. We're very highly dependent on the top surgeons, on the highly skilled surgeons. So we think we can improve this access with automation. I'm the first to mention this word, I guess, today. But the eye is quite different from the other types of surgeries that I've seen today. It's maybe more predictable, the inside of the eye. It's a nice spherical shape, and if you add sensors, you can really automate certain procedures, and of course we'll do that stepwise. So automation is a gradual process. You can just semi-automate first some subroutines and then in the end entire procedures. So we think that will be a big benefit to go into the big surgery market and also improve on the procedures that they do currently. So this is the Precise system, teller-operated system, but with the surgeon at the operating table. We call it a hybrid setup, one hand manual and the other hand robot-assisted. And we've done comparison studies between manual and robot-assisted, and we saw that we can improve on the top surgeon precision with a factor of 10 by scaling down hand motions and filtering out tremor. And it seamlessly integrates in the workflow because you only need to introduce the manipulator in certain tasks of the procedure, and you don't need to do the entire procedure with the system. So I can show a brief animation of how it works. Do we have audio? Okay, I'll do a voiceover. So that's how surgeons do it manually currently. So they have limited precision of about 0.1 millimeters, and when they want to do a precision task, they can fold in the manipulator, as you saw, and use a joystick to control the instrument inside of the eye. So it moves minimally invasively through a tiny hole, and what you don't see here is that we connect to the trocar to suppress eye movements and also to protect the thin instrument from disturbing forces of the scleral wall. So it started with 5 years of research as a collaboration between Eindhoven University of Technology and Academic Medical Center in Amsterdam. And then we did for a period research projects for pharmaceutical companies, really preclinical validation, and all these pharmaceutical companies required new drug administering procedures where you really need precision, like injecting drugs in a retinal vein. So on the backside of the eye, the veins thinner than a human hair, and you need to keep an instrument tip frozen there for multiple minutes, which is not possible by the human hand. And we could show on living pigs, anesthetized pigs, that we can enable that procedure with the robot. And a second project addressed catheterization. So we used the robot to insert the catheter in between the retina and the choroid to very accurately deliver a stem cell at the backside of the retina, which was, in the case of manual surgery, like only successful within 50% of cases, and we could reach 90% success rate, and even when vibrating engineer is doing that. So you saw in the movie of this morning that that was me in the picture. I don't have steady hands, but a robot brings the worst of surgeons to the top surgeons, I think. Then in 2015 we started to develop our first products. So we redesigned software and electronics for patient safety, and we sold that system to Nightstar, a gene therapy company, and in collaboration with University of Oxford, they performed the first robot-assisted eye surgeries. I'll show a brief movie, also no audio, but this is a BBC coverage of this first surgery. So it was very crowded in the operating theater with this film crew in there. This is the first patient, Reverend Dr. Bill Beaver, who has a membrane on his retina that gives traction, causing macular holes, causing his central vision to be lost, which you saw here. And so the procedure that was performed with this system was to peel away this epiretinal membrane. And this is the instrument manipulator. And after that, his vision was restored. You see that he is happy. And also the surgeon that was performing this surgery. And since you can't hear him, I put a quote on this slide that he thinks we can improve on the current procedures, so what they do now. So this peeling procedure was an example of the procedures that they do nowadays, but also that we can do new operations that we can't currently do with the human hand. And of course our Chief Medical Officer, Maarten Beelen, agrees that we can push the limits of eye surgery using this system. So the trial we did in Oxford was about demonstrating feasibility and safety of this membrane peeling procedure. We performed 6 patients using the robot under general anesthesia and compared them with manual surgery. And the second step was to perform subretinal injections of a blood dissolving agent. And these patients were under local anesthesia. We've performed 3 up to now. And this procedure resembles more what our final goal is in this collaboration, and that is to inject gene therapy subretinally. This is for an inherited disease, and this gene needs to be very precisely administered. It's a 2-step procedure, so first they inject viscous fluid underneath the retina, and in the second step they change instruments and go through the same retinotomy and inject the virus there. And we think with the robot we can really keep this retinotomy smaller, which would be beneficial to prevent the backflow of the virus. So this is a roadmap. The first system is really a precision device. It just follows the movement of the hand. There's no cognition there. We think that already provides the benefits to enable new procedures to enter that market. But to be able to enter the big market of the procedures that are currently performed, we think we need automation to improve access of these procedures. And in the end, by integrating 2 robotic arms with a camera system and building a console around the head of the patient to make a local sterile environment, we think we can bring eye surgery out of the OR into an office. So you see the surgeon sitting at a separate working spot at a touchscreen. So that would make it much cheaper to reduce costs of expensive operating theaters. But to enable this long roadmap, automation is required, and for that sensors are required and cameras with image analysis. So the first step, and I wanted to highlight that, is the first prerequisite of automation for us is to add a sensor in the eye that measures distances to the retina. So, for instance, to provide a parking sensor, audio feedback to the surgeon, because it's very difficult to have a good depth perception with a precision of micrometers through the microscope. So we can assist with audio feedback, but also with feedback to the robot to enable safety bounds to prevent from unwanted retinal damage. And we intend to do that using optical coherence tomography. It's an optical method well established in eye surgery. It achieves a good precision and a working distance of about 1 millimeter, but these instruments are very small. Half a millimeter is not an exception, but they even go to 0.4 or 0.3 millimeters nowadays, and they often have active functionality like a gripper that you see here. So we need to integrate optical fibers of 0.1 millimeters. We have achieved a working proof of concept, but the difficulty is that when you really want to make disposable instruments, they need to be low cost, and that's a big challenge. So I've put this slide in here because there are multiple application areas in this room, and maybe somebody sees application of such a sensor in other application areas where we could collaborate in. So then I would be very interested. That's it. Thank you.